Hey everyone, and welcome to another deep dive.
Uh,
Today we're focusing on stroke treatment.
Some really interesting stuff happening in the world of stroke treatment.
Yeah, we're going to be looking at a recent medical review article that covers all the latest. It's really fascinating stuff, even the stuff that's still being figured out.
Yeah, it's a dynamic field for sure.
So ischemic stroke, that's what happens when there's a blockage in a blood vessel in the brain. And for a while now, the go-to for that's been alteplase, right?
Right.
But it's got limitations.
Yeah, alteplase has been the gold standard for like 25 years. But yeah, like you said, it has its limitations.
It's like an old pair of shoes, comfortable but maybe not ideal anymore. So what are researchers looking at now?
Well, they're looking at Tenecteplase.
Tenecteplase. Okay, tell me more.
Basically, it's showing a lot of promise. One of the biggest things is that it's way easier to administer. We're talking a single shot versus a whole IV drip.
Oh, wow. That's a game changer right there, especially in emergency situations.
Exactly. And what's even more promising is that it's showing really great results in trials, especially for those severe strokes, the large vessel occlusions.
Hold on. Large vessel occlusion. What does that even mean?
Sorry, jargon busting. It's when there's a blockage in one of the main arteries in the brain.
Ah, I see. So back to this Tenecteplase. What kind of evidence are we talking about here?
There was this study, the XT trial, and they found that tenecteplase at a specific dose had pretty much the same results as alteplase after 3 months. Similar functional outcomes, and a similar safety profile, too.
Okay, so what's the big deal then, if they both have similar outcomes?
It's all about the how. Tenecteplase is a single injection, remember? That's huge. Especially if you think about rural areas or even just in an ambulance where setting up an IV isn't always easy or even possible.
That makes a lot of sense. Getting the treatment to the patient as quickly as possible is essential.
Exactly. And that's what makes Tenecteplase so exciting.
So is Tenecteplase the only new kid on the block, or are there others?
Oh, there are definitely others. Researchers are also looking at non-immunogenic recombinant staphylokinase.
Say that 5 times fast.
Right. And then there's recombinant human prorokinase.
Okay, I'm not even going to try that one. But seriously, why are these other options important?
Well, they might be especially important in places where it's hard to get to a hospital that can do something called endovascular thrombectomy.
Endovascular thrombectomy. More medical jargon.
Yeah, sorry. Basically, they go in with a catheter and actually remove the clot.
Wow. That's incredible. So these other medications would be backups if that's not an option.
Yeah, exactly. That's the thing about stroke treatment. It's not a one-size-fits-all situation.
Well, that makes sense, right? Every stroke is different. Every patient is different.
Exactly. And it's awesome that researchers are considering all these different situations and coming up with different options.
Absolutely. But what happens after the clot is gone? I mean, that can't be it.
Right. You're right. Even with successful clot busting, the road to recovery after a stroke can be challenging, and time is of the essence.
Time is of the essence. What do you mean by that?
Brain cells. When you have a stroke, blood stops flowing to part of the brain.
Right.
And those brain cells, they start to die. The longer that blockage is there, the worse the damage.
So it's a race against time.
Exactly. And that's why getting treatment fast is so important.
So what else can be done? Besides just getting that clot-busting medication as quickly as possible.
Well, that's where these adjunct therapies come in. Think of them as like giving your brain cells a fighting chance.
Adjunct therapies. What are we talking about here?
So these therapies, they work alongside those medications. They're like a backup team.
Okay, give me an example.
Sure. One that's showing promise is ultrasound-enhanced thrombolysis. Sonothrombolysis.
Thrombolysis.
Yeah, it's a mouthful. Basically, they use ultrasound waves along with the clot-busting meds.
So it's like giving the medication a boost.
That's a good way to put it. And there's a study, the TRUST trial, that's been looking at this for large vessel occlusions, those big blockages we talked about.
Right, right. So what about those cytoprotective strategies the article mentioned? What are those all about?
Cytoprotective strategies, they're all about protecting those brain cells from damage during a stroke.
So it's like shielding the brain while doctors work on removing the clot.
Exactly. The idea is great, but it's been hard to translate that to humans.
Oh. How so?
Well, things that work in a lab on a dish of cells don't always work the same way in a real live brain.
Right, it's way more complex.
Exactly. There was this one drug, neurintide, showed a lot of promise in animals.
And?
Didn't work out so well in a big trial with stroke patients.
Oh, that's a bummer.
Yeah, and what's even more interesting is that it might actually make alteplase less effective.
Wow, so not only did it not help, it might have actually made things worse.
That seems to be the case, based on that study at least.
That's science for you. One step forward, two steps back.
That's how it goes sometimes.
Hmm.
But it's all part of the process, figuring out what works, what doesn't.
Speaking of figuring things out, I wanted to ask about thrombectomy. That procedure where they remove the clot.
Yeah.
Seems like with all these medications, all these other therapies, you'd think that procedure would be getting even more targeted, more fine-tuned.
And you would be right. That's actually a really good point. It's not always as simple as just going in and removing the clot.
So it's not always just going in and removing the clot. Why not?
Well, a lot of times doctors will use what's called bridging therapy.
Bridging therapy.
So they'll first give the patient IV thrombolysis, the clot-busting medication.
Right.
And then they'll follow that with the thrombectomy.
Oh, so it's like softening up the clot a bit first. Makes the actual removal easier.
That's the idea. It could make the thrombectomy quicker and maybe even more effective. But the research on it isn't totally clear yet.
Right.
Some studies say bridging therapy is the way to go, others not so much.
So how do doctors decide what to do? I mean, if the evidence isn't clear-cut.
It's tough, for sure. That's where these big meta-analyses come in, like the IRIS one that was in the article.
Meta-analysis, that's where they look at a bunch of different studies, right?
Yeah, they pull all the data together to try to get a more complete picture.
And what's the verdict on bridging therapy based on those analyses?
For now, it's still recommended. But things could change as more research is done. That's the nature of science.
Always evolving. So I have to ask about those mobile stroke units. They sound amazing.
They're pretty cool. It's like a mini hospital on wheels.
A CT scanner right there in the ambulance. That's incredible.
Yeah, and they have telemedicine, so doctors can examine patients remotely.
Wow. Why aren't those everywhere yet?
They're getting there, but they are expensive, and there's a lot of logistics involved in setting them up and running them.
Makes sense.
Yeah.
But still, the potential is huge.
Absolutely. I mean, we've been talking about how critical time is when it comes to stroke.
Right.
Mobile stroke units bring the treatment to the patient. No time wasted getting to the hospital.
Exactly. I'm convinced. So the article also mentioned that the time window for treatment might be changing. What's that all about?
It used to be that if you didn't get treatment within 4.5 hours of your first symptoms, your chances weren't good.
Yeah, I've heard that.
But new imaging techniques are changing things. Debye-Flay mismatch, for example.
Debye-Flay mismatch.
It's a mouthful. It basically helps doctors see which areas of the brain are injured, but could still potentially recover.
Oh, wow. So it's like giving hope to patients who might have been told it was too late.
Exactly. And there's another one, perfusion imaging. It shows how blood is flowing in the brain.
So with these new imaging technologies, doctors can be more precise about who might benefit from treatment, even if it's been more than 4.5 hours.
Exactly. And the studies back it up. The Extend trial, the Wake Up trial, both showed positive results.
That's incredible. So much to be hopeful for.
Absolutely. And it doesn't stop there. Researchers are working on even better medications, ways to prevent those clots from coming back, and even delivering medication directly to the clot site.
Wow. This has been such an amazing deep dive. Thank you for sharing all of this with me. It's clear that stroke treatment has come a long way, but it's also clear that there's still so much more to learn.
Absolutely. And that's the exciting part.
Until next time.
See you then.